The first speaker of today's session is Dr. Haider Abbas. He's a consultant medical oncologist at Queen Elizabeth Hospital, Birmingham. He's a member of several national and international advisory boards, and he's also done his PhD during his medical oncology training. Uh, Dr. Haider Abbas.
Morning, everyone. Thank you very much for your kind introduction, and thanks to organizing committee for inviting me for this talk. So essentially, we're going to talk about some updates on management of early-stage non-small cell lung cancer, and these are my declarations. So basically, I've divided this talk into a half one for non-oncogenic non-small cell lung cancer and the non-oncogenic driven non-small cell lung cancer. So we all know that the outcome of early stage non-small cell lung cancer is really dismal. And no matter what we do, most of these patients are unfortunately would relapse within a matter of 5 years. For example, 50% of stage 1B and about 75% of stage 3 resected non-small cell lung cancer would relapse within 5 years. So what sort of management options do we have in early cancer in non-small cell? From stage 1B to 3A, we have the option of definitely the surgery. Until recently, we had adjuvant chemotherapy, which has now upgraded to perioperative chemoimmunotherapy. And in stage 3, we also have the option of chemoradiation followed by consolidation. Now, we have historically tried platinum-based doublet for in both neoadjuvant setting and adjuvant setting. And we know that there is not much difference. Therefore, the standard of care has always remained 4 cycles of platinum-based doublet in adjuvant setting. And we know that the benefit is usually in the range of 5 to 6% in 5 years, slightly more for lymph node positive disease. So recently, with the data about perioperative and adjuvant immunotherapy, the landscape has completely changed, and we are going to focus on this part of the talk for most of the talk about how this has evolved. Now, first of all, just let's clarify some of the definitions before we discuss these clinical trials. So first is adjuvant. So these are the patients who were randomized to a trial after having surgery. And in terms of non-small cell lung cancer, we are talking about 12 months of adjuvant immunotherapy. So 2 important trials here, Empower 010, looking at atezolizumab, and then pembrolizumab trial Keynote-091. And then we have the neoadjuvant and perioperative. So neoadjuvant, there is only one clinical trial, CheckMate 816, and that is the treatment given before surgery. And then perioperative, what we call the complete package, in which patients get neoadjuvant chemoimmunotherapy followed by surgery and then adjuvant immunotherapy. And there are again 3 important clinical trials here: 4 CheckMate 770 looking at nivolumab, AGEN looking at durvalumab, Keynote 671 looking at pembrolizumab. Let's start off with the adjuvant part of non-oncogenic driven cancers. Now, this is a quite busy slide. I will just try to point out some important points in all these trials. So the green trials are the ones which are adjuvant. The red is neoadjuvant, and the rest is perioperative. Now, we have to look at it. If we look at it, these are quite big trials, going from 400 to 1,400 patients in this trial. And the agents tested is anti-PD-L1 and anti-PD-1. And for all practical purposes, in non-small cell lung cancer, we think they are sort of pretty much the same. And the data you can see from metastatic in the metastatic setting would just confirm that. Other important things when you're trying to compare perioperative and adjuvant clinical trials is what portion of these patients have stage 3 lung cancer, because they have got bad prognosis. You have to be very careful, and the range is from 4 to 80%. And finally, EGFR and ALK. Most of these trials have excluded EGFR and ALK positive lung cancer. Now, historically, we know that when we talk about pre-chemoimmunotherapy data, it was 5 years disease-free survival. And at the moment, unfortunately, we don't have, we can't answer all the questions because all this data is quite recent. The only trial which has got 5 years overall survival is Empower 010, and the rest are sort of evolving. So we'll have to wait for some time for this data to mature before we have a clear idea about how these would have an impact on overall survival. In adjuvant setting, I think two very important trials, they have essentially showcased the importance of adjuvant immunotherapy in non-small cell lung cancer. Um, Empower 010 looking at atezolizumab and PEARLS, or Keynote 91 looking at pembrolizumab. The randomized population was stage 1B to 3A non-small cell lung cancer, or in other words, the tumor should be at least 4 centimeters without lymph node or lymph node positive. And these trials have resulted in two in these survival curves which you can see. And without going in further details of statistical analysis, we can see that essentially they look the same, not much different from each other, and they got approval in different indications in different settings. Now, Empower 010, atezolizumab, essentially patients who were eligible had surgery, had adjuvant chemotherapy, and then randomized to 12 months of adjuvant chemotherapy. And in this particular trial, the primary endpoint was tested in hierarchical way. First in PD-L1 high, then in all randomized patients, and finally in cancer-free population. And you can see that it was a positive trial in PD-L1 positive and in all randomized trials. Now, important question comes up. Is there any relation between PD-L1 positivity and the benefit that you get? Because that's what we have been seeing in metastatic settings. Higher the PD-L1 expression, more benefit you get from immunotherapy. And if you look at the graph just at the right-hand side, what it is split the PD-L1 positive into greater than 50% and less than 50%. So for all comers, hazard ratio was around 0.6. PD-L1 greater than 50%, hazard ratio was around 0.4, and PD-L1 less than 50% is 0.3. So a clear benefit for patients with PD-L1 greater than 50%. And that's what the EMA and the UK has given it a registration, whereas in FDA they've got of all randomized. And this is OS and DFS for PD-L1 positive. On the left-hand side, it is PD-L1 positive for all of them, and on the right-hand side is PD-L1 greater than 50%. And here you can see a clear benefit in terms of OS and DFS in the PD-L1 high group. Now, Keynote 091, it is looking at pembrolizumab in pretty much similar settings, but it has got dual primary endpoints. And the first group was to look at PD-L1 greater than 50%, and then all comers, all randomized. Now, it has a very good reason why they showed this, because pembrolizumab has an outstanding efficacy in PD-L1 high metastatic settings. Now, on the left-hand side, in both of these trials, on the right-hand side, you can see the PD-L1 positive group, and it's the negative trial for PD-L1 greater than 50. It came as a shock because it was very much expected. We had the results of atezolizumab trial that was positive for greater than 50. We had the metastatic setting positive for PD-L1 50, but it was negative. They tried to explain it. They tried to explain it in a number of ways, saying that probably the control arm performed much better, but it was very difficult to defend. However, it got a license for all comers rather than just PD-L1 greater than 50. Now, DR31 is a very interesting trial. It's an interesting academic trial looking at durvalumab in the pretty much similar setting. It is slightly different from previous two trials, and I explained them to you. First of all, chemotherapy was not essential. Patients were not well enough or could not proceed with chemotherapy, they were still being treated. Number two, randomization was 2-to-1 rather than 1-to-1. And you know that once you do this, you lose the power. And number three, it has very stringent surgical criteria. So this is how it was different. And they were looking at PD-L1 greater than 25%. And it is a negative trial. Once again, it was a surprise because we were expecting PD-L1 positive to be a positive trial, particularly greater than 25 or greater than 50. Now, they've tried to explain it and give the reasons why it could be. And this is how they say. Now, the problem here was they had a very stringent criteria for surgery, which is very difficult to meet. And what it has done, it has just chosen the best of the best patients. And the control arm has improved so much that there was no opportunity for the experimental arm to outperform. For example, the control arm in Empower trial, the median event-free survival was 37 months. In the pembrolizumab arm, the control arm it was 42 months. But in this trial, it was 54 months for the control arm which means that the control arm was so good that even the experimental arm was good, but it could not be. Now, going into neoadjuvant and perioperative setting, what is the clinical rationale of going for neoadjuvant treatment? We know that one of the main reasons why we do this is to bring down the tumor and have better surgical response. We also identify our patients who are at high risk, patients who do not achieve pathological response. You can do further studies to titrate their treatment. And what are the causes? We are always worried about the disease progression on neoadjuvant systemic treatment. And about 5 to 10% of patients will not even make the surgery to get their own systemic treatment. We are worried about delays in surgery because of military toxicity. And the surgery becomes very complex because of the fibrosis and all that goes because of the systemic treatment. And what does the preclinical data tells us? If you look at these mouse models for triple-negative breast cancer, it clearly shows that the ones who received neoadjuvant systemic treatment before having resection, the outcome was much better. And finally, what have we learned from other tumor types? Now, if you split in melanoma, if you split 18 cycles of adjuvant nivolumab into 3 before and 15 after, versus 18 cycles of adjuvant immunotherapy, it improves the event-free survival remarkably. And the hazard ratio is somewhere in the range of 0.58. So just moving 3 cycles in neoadjuvant setting, you can see this difference. And one of the pivotal trials presented earlier this year, the Medina trial, it compared 2 cycles of ipi-nivo versus 1 year of adjuvant nivolumab. And you can see the difference. So all in all, we have enough evidence to say that neoadjuvant or perioperative should be better. So these are the trials that we have in a neoadjuvant or perioperative setting. Out of all these trials, there is only one trial, Checkmate 816, of all perioperative. The number of cycles given, majority of them is 4, but some trials have also chosen to go for 3 cycles, and PFS is primary endpoint for most of them, and some have included PCR as well. So these are the 4 trials that I would like to focus on. First of all, the trials on the left, Checkmate 816 and Checkmate 717. I will have a look at them together because they both use nivolumab. Now, look at their event-free survival. Checkmate 816, remember, is a neoadjuvant trial. There is Checkmate 717, that's a nivolumab perioperative trial. Essentially, they both look the same. We should not be comparing trials, especially when the trial design is different, but we are actually looking at perioperative and neoadjuvant way of treating patients. So one thing we can very clearly say is a very effective way of treating. With a hazard ratio slightly in favor of perioperative rather than neoadjuvant. Now, Checkmate 816 4-year OS was recently presented, and unfortunately, it is not clinically significant. One other thing that we looked at in Checkmate 816 was looking at subgroups treated with either carboplatin or cisplatin. Now, we have religiously used it as a religion, the cisplatin in adjuvant setting of curative intent treatment. And it was considered that carboplatin does not help. It was based on a clinical trial in which when carboplatin was offered, the outcomes were a bit inferior. But in this trial, if you can see, I'm not going to say which one is better than the other one, but there's a clear indication that about 40% of patients of the clinicians use carboplatin, and it is as good as cisplatin stable. Another very important thing in 770, when you're looking at neoadjuvant treatment, N2 becomes very important. These are the patients who have big disease burden, and at times very difficult to just operate or bring them down in terms of that treat response. So in 770, they looked at patients with N2 disease or non-N3. And it's very nice to see that pathological treat response in both these groups were very much comparable. What does it tell us? It tells us even locally advanced N2 disease can be cured or treated with immunotherapy in a similar fashion as early non-N2 disease. Now, these are the other 2 perioperative treatment budgets. Asian looking at nivolumab and KEYNOTE-671 looking at nivolumab. And once again, both of these trials look pretty much similar, not much difference, hazard ratio of 0.59. And secondly, pathological complete response. Now, pre-immunotherapy era, the pathological complete response with chemotherapy was only 2%. with all these perioperative and new adjuvant setting immunotherapy has come somewhere in the range of 20%. And that has been consistent throughout all of these clinical trials. Now, Asian also looked at N2. On the left-hand side is non-N2, and the right-hand side is infection disease population. And if you look at 24-month mark, it is exactly the same whether patients are N2 or non-N2. Again, sort of the same point here again, the two N2 disease response rate. So out of all these trials, adjuvant, the perioperative, the new adjuvant, only trial that is positive for OS is 671. It's the pembrolizumab perioperative trial, and this is the only one which is positive at the moment. And if you look at irrespective of the stage, irrespective of those stages, irrespective of PD-L1, it just works for everything. So how would we summarize the trial, the new adjuvant and for perioperative trials? All of the trials were positive for EFS, but only 671 was positive for OS. We are awaiting segment 773 OS data. It's not going to show you. Now, there were some concerns. I will try to address some of the questions that sort of arose with chemotherapy coming in. There were issues about cancellation of surgery because of new adjuvant therapy. And it has actually improved all the surgical outcomes. There was no delay, and most of these patients went for surgery have perioperative therapy. Now, is perioperative good enough for stage 2 and PD-L1 negative tumors? Individual trials have less number of patients, therefore they have to look for meta-analysis. And this meta-analysis published in 2024 in JAMA. I think there were two in the same edition. And it clearly shows that irrespective of PD-L1 status or stage, therapy is effective in perioperative studies. So how much immunotherapy should we give and for how long? I think we know it from KEYNOTE-671 because that is the only trial is positive for OS, so that should be the center of care. Finally, I'll just touch on a couple of landmark analysis. So what is actually landmark analysis? It's basically exploitation of the data that we have, but it tries to answer some really important questions. For example, is there any benefit of adjuvant nivolumab once we have achieved pathological complete response? So here your landmark, your analysis starts from surgery rather than before surgery. If you look at here, whether fat CR or no fat CR, nivolumab has a role. Second landmark analysis is done in KEYNOTE-671, and pretty much similar response. Whether you have fat CR or non-fat CR, you still need to carry on with immunotherapy and you derive benefit. Now moving on to the oncogenic part, oncogenic-driven cancer, which is a bit shorter, I'll just focus on that. So we know that over the last decade and a half, there's been a remarkable improvement in the targeted treatment that we have, primarily EGFR and ALK. And it was very natural for this to go back to bring it back into the curative intent and see if it's different. So I'll essentially focus on the EGFR and ALK. There are a number of trials going on, but I'll only focus on a couple of these trials. So EGFR positive, we have this in 2008, and a number of trials have been done in adjuvant settings, primarily first generation CPI. And I've just listed 4 here, and out of these, 2 very recent trials were positive for EGFR. And really, with a hazard ratio of 0.4, it's really remarkable. And you'd expect it to translate into overall survival. But unfortunately, all of them failed. All of them were not statistically significant for OS, and hence we did not get this movie. But then we move on to alternative is of 4th generation for CPI. A difference between this and the previous generation CPI is that it not only attaches, it not only works on T790M mutation, which is required resistance mutation, but also it has got blood-brain barrier. It can cross blood-brain barrier, which makes it much better in terms of controlling CNS disease, which is a big issue with oncogenic-driven cancer. So, ADORA trial is basically randomized patients who have resectable non-small cell lung cancer with EGFR mutation, stage 1B to 3A. So if patients were removable from chemotherapy, after chemotherapy, they were to have osimertinib for 3 years. And you remember this, you all know this, it was a positive trial uh, for stage 1 BCCA and then also from 1 BCC. And I think it was a lot of, yes, we knew that this is going to be positive, but the main question was, is it going to follow the same pattern what we had previously, positive for EFS, middle class weight into OSD, and it was the first ever trial, which was positive for over its overall survival, and hence we got it proven. We know that OS benefit is more for stage 3 as compared to stage 1, but still even in stage 1 it's good enough. Secondary endpoint, improved CNS outcome, as I previously mentioned, it has the ability of crossing the blood-brain barrier, and hence CNS recurrence was much less with osimertinib. About 60% of patients had chemotherapy in this trial, and they also looked at if would chemotherapy make any difference. There was slight improving trend towards patients who had chemotherapy, but not no, because it was 0.49 for adjuvant chemotherapy and 0.47 for no adjuvant chemotherapy. So what actually it means? Osimertinib is approved in adjuvant setting for 3 years for patients who have resectable non-small cell lung cancer with EGFR mutation. It has also resulted in some more trials using osimertinib in neoadjuvant setting, using also moving osimertinib to 5 years rather than 3 years. And further trials are ongoing as well. Now, finally, ALK mutation positive. I think this follows pretty much the same as what we have seen with EGFR mutation positive. Pretty much similar trial design, but there was one difference. Here, after 30 patients were randomized to alectinib versus chemotherapy, so there was no option of chemotherapy for everyone. They're all ALK range. It was presented a bit later on because you know that ALK range cancers about 1 to 5%. It's much smaller group. Most of these patients were presenting metastatic with a metastatic disease. It's very, very difficult to find this group of patients and then do a clinical trial. And as we expected, it was a positive trial presented last year for disease-free survival, and hence it got its registration. Again, pretty much similar. EFS was better, was more for stage 3 as compared to stage 1, but still there was benefit. Pretty much similar story with CNS disease, its ability to cross blood-brain barrier and hence reduce the risk of CNS recurrence. So now alectinib is approved for 2 years rather than 3 years as we did in osimertinib, and it has also resulted in some more clinical trials moving alectinib in neoadjuvant setting and using it with immunotherapy as well.
Thank you very much, Dr. Bhatt. Our next speaker is Professor Abbas Coker. He's the head of department at King Edward Medical University and Mayo Hospital. Professor Coker and his team, they are actively involved in international clinical trials. He's also a supervisor of undergraduate and postgraduate training programs. And he will give us some updates on metastatic non-small cell lung cancer without oncogenic disease. Thank you, Doctor. Uh, Part without the consent. So that only the corporations that have and are they are available and the targeting countries that are available on these are going forward in terms of this category without also the the society for the course we would like to touch upon this. So today's overview of our talk. We would like to discuss the first-line management of non-oncogenic non-small cell lung cancer, optimal treatment strategy for PD-L1 high patients, predictive factors for the response to immune checkpoint inhibitors, and we would also like to discuss the patient characteristics and cancer characteristics in this regard.
the potential benefit of dual checkpoint blockade, when to consider the safe discontinuation for the long-term responders, effective subsequent lines of treatment and future approach. It has a practical application that the current sustained treatment opportunities and corresponding major trial results will be discussed today. Routine clinical practices like basic notes to the level high pressure, significance of dual checkpoint blockers, and the discontinuation strategy. And we would also like to explore the second-line treatment methods after immune checkpoint inhibitor, failure such as antibody drug conjugates, and the role of tumor microenvironment. We would also like to give an overview of the ongoing first-line trials and the treatment strategies. So, what are the conventional management for the advanced lung cancer? We know that chemotherapy has long been the standard of care in the pre-immune checkpoint inhibitor era, and therapies that were used mainly there were chemotherapies, chemotherapy-based therapies, chemotherapy-based platinum doublets, and then used to do the which use the taxanes in this particular setting. And with the advent of a new era in which the immune checkpoint inhibitors were discovered, the PD-L1 4, the therapy was reshaped, and we know that PD-L1 has been in most of the regimes which are being used in most of the lung cancer types. So this is a very slide, and I will go into detail into this. That this is a list of different trials in which PD-L1 inhibitors were used, and they proved their efficacy with the PD-L1 less than 1% and PD-L1 more than 50%, the high expressor cohorts. Since 2015, we are seeing many trials and many approvals by the FDA for the immune checkpoint inhibitors in our they are being used now in non-small cell lung cancer. Just to touch upon the therapies which have been approved in non-small cell lung cancer, one of them is pembrolizumab. In the KEYNOTE-024 trial, the famous trial, in which 305 patients were included, they were all treatment-naive patients, and they were given pembrolizumab monotherapy 200 milligram every 3 weeks, compared with the platinum-based doublet therapies. And you can see that the cervical curves are beautifully separating. This the other trial in this regard was the KEYNOTE-042, in which again the pembrolizumab was used in about more than 1,200 patients. In the PD-L1 positive patients, which were 1% or more than 1%, and the pembrolizumab showed a response in terms of overall survival 16.7 versus 12.1 month, and hazard ratio was 0.81, and the outcome was mainly driven by the PD-L1 high expressors. And consequently, the FDA approved the pembrolizumab for patients with PD-L1 expression more than 1%. These are the survival curves of KEYNOTE-042. Then comes the Empower Lung 01 trial, in which cemiplimab was used versus chemotherapy. 563 patients were enrolled in this trial, and the PD-L1 of more than 50% was the criteria. 15% were having stage 3 disease not suitable for the resection or chemotherapy, and the results were quite in favor of cemiplimab, with progression-free survival of hazard ratio of 0.54 and overall survival of ratio of 0.57, and led to the approval by the FDA and EMA in 2021. So this trial, the cemiplimab drug, that was this ICI was consistently prolonging the survival, and the 3 years follow-up and 3-year follow-up was also encouraging, which the 3 years follow-up, it was also encouraging in terms of overall survival, And it was also encouraging in PFS2 and OS2. That means the use of this ICI beyond progression. Then comes the Empower 110 trial, in which 572 patients were enrolled, and they were all treatment naive. The criteria was PD-L1 more than 1%. Atezolizumab was compared with the chemotherapy, and the results, the progression-free survival and overall survival were very encouraging. Having a ratio of 0.63 in terms of progression-free survival, and overall survival of 0.59 hazard ratio was quite good, and it led to the FDA approval of this immune checkpoint inhibitor in 2020 and the EMA approval in 2021. Then comes ICI as combination. Previously, we had discussed the ICI as monotherapy, but now we are going to discuss the immune checkpoint inhibitors in combination with the chemotherapies. And in non-small cell non-squamous lung cancer, in Keynote 189 trial, with 616 patients were enrolled. Pembrolizumab with chemotherapy, platinum doublet was compared with chemotherapy alone, and it showed better results as compared to the chemotherapy, with a progression-free survival with a hazard ratio of 0.50 and overall survival with a hazard ratio of 0.6. It comes in our 150 study, in which 1,202 patients were enrolled. There were 3 arms: carboplatin, paclitaxel, bevacizumab. Then comes carboplatin ABCB arm, in which the carboplatin, paclitaxel, bevacizumab, and atezolizumab was added. And then comes the third arm, in which carboplatin, paclitaxel, and atezolizumab was the agent. And the study allowed the inclusion of EGFR in ALK-positive patients as well, for failure of the targeted therapy. So the results were again very encouraging in both a wild type and the EGFR mutated patients. And consequent to this trial, the ABCD is approved irrespective of PD-L1 status as first-line treatment, and for the repeat EGFR, ALK, and EGFR and ALK-positive patients. Then there is Empower 130 trial, which is included 723 patients. Carboplatin, paclitaxel, and atezo were used, and the progression-free survival and overall survival were in favor of using the checkpoint inhibitors. What about squamous cell non-small cell lung cancer? A Keynote 407 study was designed for this particular type of disease, and carboplatin, paclitaxel was combined with pembrolizumab. And despite the crossover rate of 51%, the combination showed improvement in the progression-free survival with hazard ratio of 0.59, overall survival of 0.71, regardless of PD-L1 expression. However, the overall survival benefit in the PD-L1 negative patient decreased with a longer follow-up. Then comes Empower Lung 03 study, in which cemiplimab was tested in stage 4 or palliative stage 3 in non-small cell lung cancer. And the trial was also, again, it was in favor of immune checkpoint inhibitors with a hazard ratio of 0.71 in terms of overall survival. We put this drug in 2023 in this setting. So coming to the ICI combination, that is CTLA-4 and PD-L1 inhibitors, combining them together for non-small cell lung cancer. And actually, 227 trial was designed for this particular purpose. A dual checkpoint blockade versus chemotherapy was tried. Total number of patients including for 1189 with PD-L1 positive disease, and 373 patients were enrolled with PD-L1 negative disease. And they were randomly assigned to the 1-1-1 fashion. And that means PD-L1 positive and PD-L1 negative. They were randomized to the nivolumab and ipilimumab, versus Nivu versus chemotherapy. And trial was stopped early because of significant odds of survival benefit in favor of Nivolumab plus chemotherapy with a hazard ratio of 0.71, and the advantage was maintained during the follow-up with the overall survival hazard ratio of 0.65. In 2027, long-term follow-up after 5 years and 6 years, the difference was maintained in favor of dual checkpoint blockade. Uh, and Nivolumab and Nivolumab has been granted approval by the FDA, irrespective of PD-L1 expression. And another trial which was testing combination of PD-1 and CTLA-4 inhibitors, checkmate 9LA trial. The 719 patients were enrolled in this trial. The chemotherapy was added along with this dual blockade. And the rationale of adding chemotherapy in the intervention arm was an increased early mortality observed in trials with ICA combination therapy alone compared with the standard chemotherapy. And the hazard ratio of 0.72 in terms of overall survival was seen. Post-hoc analysis were also favoring, especially for patients with absent PD-L1 expression and squamous cell response. Another trial, recent trial in which again the dual blockade with durvalumab and durvalumab were tried with chemotherapy versus chemotherapy alone, and in the first analysis durvalumab and chemotherapy of chemotherapy improved the progression-free survival versus chemotherapy alone. Now coming to the high expressors, the PD-1 that were high expressors. Treatment opportunity for chemotherapy-free monotherapy in a patient population with a median age of older than 70 years and relevant tumor, which appears appealing. However, ICA monotherapy may not be sufficient for all the patients, and there is an urgent medical need to identify those who need the combination treatment. Indirect comparison of ICA monotherapy versus combining with the chemotherapy in PD-1, PD-L1 more than 50%. Indirect comparison indirect comparison of POT versus OA PO 1895 shows that improved response rates for a short-term or short-time to remission and trend towards improved overall survival was seen. And in general, the indirect comparison showed overall response rate and progression-free survival with improved using combination therapy, but overall survival remained unchanged. These are patient-related markers which can be used to assess the patients and offer them monotherapy versus combination therapy. And we have seen that the patients are male patients who are elderly, more than 75 years of age, having PD-L1 expression of more than 50 or more than 90%, having KRAS, G12C, or TP53 one had good response to the L1 therapy compared to the females and having non-smokers and having other mutations. There's a large meta-analysis in gender differences and shows that the hazard ratio of overall survival of ICA-based treatment versus control. The males were having 0.72. Females 0.86, the males were deriving more benefit from the ICA combination as compared to the slide in interest of time. I'm sorry, I'm already going to so this is the KRAS and TP15 mutation. They are again favoring the ICI immune checkpoint inhibitor therapy because the trials have shown that we have a highest overall response rate, longer duration of response, and longer duration of survival. There are certain negative predictors for ICA response, and the moleculars are STK11 mutation and KE1 mutations. These are considered negative predictors in terms of KRAS mutation for non-small cell lung cancer. They do not benefit much with the addition of the immune checkpoint inhibitors. This is actually the retrospective data, and the prospective data is being tested, and there are two trials in the United States and France being run over this. Now the question comes: what is the role of dual checkpoint blockade? The dual checkpoint blockade was addressed in now and remote study, and the PD-L1 negative patient had some substantial resistance survival benefit compared with chemotherapy versus this combination of dual. Squamous cell carcinoma were particularly taking benefit with this dual checkpoint blockade, and as we show for overall survival, with squamous histology 1.64 as compared to non-squamous histology with 1.75. When to discontinue the ICI in long-term responders? Actually, there is no correct answer for this. However, most of the trials were designed for 2 years. However, if the patient is tolerating it well, they can be continued, and they may be continued in patients. The other question is second-line treatment options after progression on ICI. Again, this is an open area. The trials are being run, but there is no clear answer for this. However, the docetaxel or docetaxel combining with VEGF like nintedanib and ramucirumab are probably the options to go for in second line versus after failure of the immune checkpoint inhibitors. There are certain trials which are being run after ICI failure. One of them is the Symposium trial in which docetaxel and ramucirumab have shown consistent results, and it is again the data is consistent with the retrospective analysis as well. Administration of ICI after disease progression. There was a study which phase 2 done MAP 1800 trial, which pembrolizumab was combined with ramucirumab. Improved, but results are not statistically significant, and progression-free survival with a hazard ratio of 0.86 and overall survival of 0.69 was observed versus standard of care. It is still an open area. Future approaches, there are certain targets that have been identified, and the antibody drug conjugates is the future of this area in which antibody is tagged with a payload, and the chemotherapies are that use small molecules with antibodies are so effective, and they have less toxicity because they hit the target. And there are the markers which have been identified. There are TROP2, MET, and carcinoembryonic degenerate cell adhesion molecule 5. And there are two trials, phase 3 TROP1 and phase 3 Carmen trials, which are in, and they have shown results in favor of these antibody drug conjugates. Then there is a phase 3 trial, both trials, which is also testing this symposium for in antibody drug conjugate setting. Summary and clinical statement: ICI-based treatment stand as the current first-line standard of care for the suitable patients with monogenic non-small cell lung cancer. PD-L1 expression correlates with immune checkpoint inhibitor effectiveness, although high expression does not always ensure a robust immune response. Monotherapy presents an effective option for PD. One high expression with favorable tolerability compared with the chemotherapy or ICI chemotherapy combinations. Dual checkpoint inhibitors may be in particular effective in special populations like squamous cell and or PD-L1 negative non-small cell lung cancers. The future focus lies on identifying predictive markers to guide optimal individual treatment strategies. This necessitates addressing the challenge of determining the safe discontinuation strategy for long-term responders. Second-line treatment post-ICI are still underexplored, and for promising future prospects involved exploring ADCs and polymer conjugates, among others. The transition of incurable lung cancer to chronic disease has started with the implementation of ICIs and has promised to continue with the integration of novel concepts. Thank you very much.
Thank you very much, Dr. Coker. Our next speaker is Dr. Hizar Khan. He's a consultant pulmonary physician and general medicine physician at Harrogate District Hospital, UK. He played a leading role in establishing KEBUS and IPC services in the region. He's also a clinical and an educational supervisor for the foundation trainings and the core medical trainings in UK. Welcome.
Thank you for having me here. Really honored. So the topic is the role of interventional pulmonology in lung cancer. The, the reason why I picked up this topic is because there are 1.7 billion deaths worldwide lung cancer, and most of these can be treated effectively with early diagnosis and appropriate treatment. This is my hospital, Harrogate District Hospital, North Yorkshire. So Michael Simov is considered as the interventional pulmonologist, a pioneer in interventional pulmonology. Said that interventional pulmonology provides invasive, minimally invasive options that can improve quality of life and outcome in patients with lung cancer. And by definition, interventional pulmonology is a subspecialty of pulmonary medicine, focusing on minimally invasive procedure to diagnose and manage thoracic diseases, including lung cancer. The objectives are to enhance patient outcomes through advanced diagnostic and therapeutic techniques. These are some statistics from National Lung Audit 2024. And you can see that half of the patients are diagnosed at stage 4, and only about 30% of the patients get diagnosed at stage 1 and 2. And that has got significant effect on prognosis over 5 years. So with stage 1, you can see that 65% of people survive for 5 years or more, whereas it drops down to only 5% at stage 4 cancer. So the challenge here is that the lung cancer is often diagnosed at later stages. And the reason behind this is that the patients are asymptomatic at an early stage. They only start getting symptoms of cough, weight loss, or hemoptysis when the cancer has unfortunately progressed. So early and precise diagnosis is crucial for improving survival rates. And there comes the role of interventional pulmonology, which provides advanced tools for early stage detection and accurate treatment. So the UK first rolled out the screening program in 2011, which was a huge success. And it was a piloted program in high-risk areas. Since then, following the success of that program, since 2022, it has been spread out to most of the part of the UK which are high risk. And the criteria for targeted screening is that the patient has to be 55 to 74 years of age. In USA, it goes up to 80 years and has to be a current smoker of at least 25 years. And the diagnostic tool that is used is the low-dose CT scan. So there are various procedures that are used related into diagnostic and therapeutic procedures. So I'm sure most of you would have known about conventional bronchoscopy, which is mainly used to, particularly in context of lung cancer. Conventional bronchoscopy is used to pick up on big tumors that are in the central airway, and we can actually take biopsies and get a diagnosis. But navigational bronchoscopy is nowadays used in most of the tertiary care centers in UK. And due to the result of this screening, we pick up a lot of lung nodules, which could be benign or malignant. But the only way of diagnosing it is by doing these procedures. So what happens in navigational bronchoscopy? It is actually done in various stages. And the first stage is basically to obtain the CAT protocol images, which is then fed into the particular software. And then virtual bronchoscopy and a path to reach the target lesion is achieved. Then on the day of the procedure, patient is placed on an electromagnetic probe, which creates an electromagnetic field around the patient, and it just works like a navigator. So while doing the procedure, you can actually track the scope and can reach the target lesion and take the biopsies. So the study in 2020 showed that the diagnostic yield of this procedure is about 70 to 94% for picking up peripheral lung nodules. The next one is VATS, video-assisted thoracoscopy. This is unlike thoracic VATS, which is actually an extensive procedure. It is quite similar, but the way it is different is that it is less invasive. It's done as a day case, and only a local anesthesia is required. Thoracic VATS is mainly used to take part of the lung out, lobectomies, and performing other procedures, whereas this one is basically used to pick up pleural nodules. It is also used as a therapeutic procedure for pleural effusions, malignant pleural effusions, and to drain them, also to fluids, we call it Podraj, where we instill a talcum powder sprayed inside, and that leads to sticking of the lining of the pleura and prevents future accumulation of fluid. This was the MIST trial that was done in 2011 that actually showed the efficacy of VATS fluoridesis as compared to simple pleural aspiration and talc fluoridesis that is usually performed for managing these malignant pleural effusions. This is how we do the procedure. Basically, it's done under local anesthesia, and the patient is given put on the side. It's obviously done in a sterile environment. We give about 1 centimeter of incision, insert a trocar, and with the help of the trocar, we advance the thoracoscope. Flexible as well as the rigid scopes are used. My own practices, we have got the rigid thoracoscope in our facility. And then through this instrument, you can see there is a port where you can insert the guide wires, you can insert the instruments to obtain the tissues. The second picture, you can see that that's how you actually visualize the pleura, where you can see if there is any abnormality, you can actually take the biopsies. There's a suction tube attached with the thoracoscope, and you can actually drain all of the fluid out, and then instill the Podraj, which is talcum powder, which induces inflammation and it sticks both linings of the pleura together. So the other diagnostic procedure is endobronchial ultrasound scan. So I've been involved in setting up a service for EBUS in my hospital. We had to send patients across to the tertiary care center and for diagnosis of pulmonary cancer. So this is very similar to, it is a bronchoscope with an ultrasound scan at the end. And this procedure is mainly used to um, in staging of the lung cancer, and basically the lymph nodes that are not visible through the simple bronchoscope, and you can actually see through those through the airways, assess the lymph nodes, and any lymph node over 0.5 millimeter can be biopsied. And I'm aware that in Pakistan, it's only Shaukat Khanum where the process is performed, and the rest of the countries usually they either rely on PET scan images for the staging of the cancer, or they go with the mediastinoscopy, a surgical procedure to stage the cancer, which is quite an extensive procedure and has got quite high risk of complications. So this is pretty safe procedure and is done as a day case procedure, and the diagnostic yield is extremely good, um, and obviously less invasive. You can see that this is a diagram showing about how we classify. I'm sure most of you are oncologists and very well aware of the staging of cancer. So for those who don't know, you can see that there is a tumor sitting on the right lung, and then there are lymph nodes at station 10 and 11. So these are called Highland lymph nodes. For this particular cancer on the right side, if the N at the station 11 or 10 are positive, it becomes N1 disease. And if the station at 7 or 2 or 4 are positive, it becomes N2 disease, whereas the contralateral stations, if they become positive, then it gives as N3 disease. And that would have major impact on the staging of the cancer. Scan quite often you pick up lung nodules that are quite far away and you can't reach through the procedure. For those being test, and then to Canon you can advance the radial EVA, a guide sheet that goes far up to the distal end, and then through real-time ultrasound guidance you can reach the lymph nodes that are far away but alongside or adjacent to the distal airway. Now, the difference between the navigational bronchoscopy and radial EVA, both are used for peripheral lung nodules or regions, but for navigational bronchoscopy, it's mainly for those regions that are sitting in the periphery and does not have to be along the airways or adjacent to the airways. And it's mainly done with the help of the electromagnetic radiations in a real-time guidance. Whereas radial EVAs is for those peripheral regions or nodules that are adjacent to or close to the airway, and it's done under real-time guidance with fluoroscopic guidance. There are some procedures that are used for the management of malignant pleural effusions. One of them is IPC, indwelling pleural catheter. This is again the service that I have been using to my hospital. This is a PGH hospital, and we had to send patients over to a tertiary care center where they would get these procedures done. There have been various trials that have shown the efficacy of the pleural of the IPC in managing malignant effusions. So this is the way how we do the procedure. There are indications to perform the procedure. The main indications are that patient has got advanced lung cancer with recurrent pleural effusions, and the prognosis is between at least 2 to 12 months. Those are the patients that will benefit from this procedure. So what happens again, it's a day case procedure. So as you're aware that patients with advanced lung cancer, they require recurrent hospital admissions, wouldn't impact on the overall prognosis, but obviously it has got great effect on the quality of life and the last few months that they have to spend. So this is a day case procedure, and what happens, we bring the patient in, done under all aseptic technique. We make 2 incisions about 5 centimeters apart, and then with the help of ultrasound guidance, we identify the area where we need to insert the IPC, create a tunnel. One end goes into the pleural space, and the other end comes out. And then we apply stitches for the first few days. In UK, we have got community nurses to visit, make sure that it's nice and clean, and then 3 times, at least 2 to 3 times, they do and perform regular drainage. We provide the negative suction bottle, which is about 500 mils, and it can be drained. Once the patient is confident, they can actually do it themselves. Even the community nurses don't have to do it. There are some other procedures such as tumor debulking. These are again the palliative procedures for patients with advanced tumors in the central airways. You can effectively remove it with rigid bronchoscopy, and studies have shown that it improves the patient experience and provides symptomatic relief in as 70 to 80% of cases. And then there are airway stents, which are also used. There are various kind of stents, such as silicone stents, as well as metal stents that are used. Again, these are the procedures that are used for advanced lung cancer. Here is an example. As you can see that in this particular picture, there is an intrahilar mass around the left of the lobe, which is also obstructing the airway. So it can be approached with 2-way procedure. The tumor that is visible can be actually resected, and then you can see that they have applied a Y stent, which can be a silicone, or some places they use metal stent. That actually effectively relieves the symptoms. So advantages of interventional pulmonology. So minimally invasive, reduced recovery time and complications, high diagnostic yield, also small and complex lesions, and procedure is often performed on an outpatient basis with less risk. To be honest, that is true for most of the cases, most of the procedures that we perform. Challenges, obviously there is limited access to advanced inpatient interventional procedure techniques in some regions, not only in Pakistan, obviously in UK, most of the DTH hospitals, they don't have all these facilities. And as I mentioned, in my own hospital, I've only started working as a consultant for the past 3 years. We did not have the facility of IPC insertion. We did not have EBUS, and patients had to wait to go to Leeds to get these procedures done. It needs specialized training and obviously equipment. And then in future, there are integration of AI and robotics to enhance the precision, and expanded use of IP and personalized cancer treatment plan. So in summary, the interventional pulmonology play a critical role in both the diagnostic and management of lung cancer, offering minimally invasive procedures, accurate and effective options. Continue research and investment in interventional pulmonology are essential for advancing lung cancer. That's my team. Endoscopy team.
Thank you very much, Dr. Khan. Our next speaker is Dr. Zishan Ansar. He's the assistant professor and head of molecular pathology at our hospital, Karachi. He completed his residency in heme pathology and pursued a fellowship in molecular pathology. He's also a supervisor of the molecular pathology fellowship program. And he will discuss the role of NGS in thoracic malignancies. Thank you, Dr. Zishan.
Thank you for the introduction, and uh, I'll try my best to, keep you attentive. And thank you for organizing the meeting to invite me. So, as Dr. Abdullah said, my topic is role of next generation sequencing in thoracic cancer. I'll be focused on lung cancer. I have nothing to disclose, and I'm going to discuss about the main concept of molecular testing, which is the next generation sequencing testing, the diagnostic historical overview. Then I'll be discussing the foundational knowledge about the NGS, the recommended biomarker available for lung cancer, role of liquid biopsy, which is the new, application or the technique available, and the challenges and the limitation for NGS tissue and liquid biopsy. So I'm not going to classify every malignant tumor in the thoracic cancer. Again, I'm not going to discuss the detailed method of NGS, but the application and the limitation is much important. And I'm also not making you the molecular oncologist here. So the historical background is, around 200 years back, once the Mendelian's law was discovered. It takes around, 1 year, 100 years to identify the DNA structure. Then the one very known scientist from the Sanger Institute, the Frederick Sanger, he discovered the Sanger sequencing, and he got two Nobel Prizes, one for Sanger sequencing and one for insulin discovery. And then the polymerase chain reaction to target the DNA for different variants, and then the Human Genome Project from different countries, and then the discoveries of these massive parallel sequencing or the next generation sequencing is comes in the routine of diagnosis. So why actually we need to do mutation test for the the in oncology or any cancer or any disease, actually to know the diagnostic information, characterization of the disease, predictive information, which is very important for the cancer, especially for the personalized medicine or the personalized oncology for the actionable mutation, and also it gives you the prognostic information and the measurable disease for follow-up model. This is the main reason to do, and how the molecular testing is evolved. It's actually start from karyotyping, identify the karyotype, the chromosome, its arrangement, and take the abnormality. Then from chromosome, they, you know, go to more higher site of the chromosome, which is interfaced by fish, more higher site for DNA, and then the more higher site for the DNA basis. So this is how, from globe to region to one specific region, it's evolving from chromosome, fish, and the basis for sequencing by Sanger and the next generation. So the basic, actually the concept to understand the sequencing, the first generation sequencing is give you just a chain reaction from 1, 2, 3, 4, 5, 6, 7. It not give you the depth of sequence of the depth of presence of the clone present in the cancer. But the next generation sequencing give you the change in the sequence and the depth of the sequence of. So this is the one innovation that the NGS has developed. So by scaling or the measurement, if I ask or compare with the other method, the NGS is more scalable to sequence and more sensitive to check the depth of the clone, and also it will give you the known novel or unknown novel variant, which is you cannot pick by the the small technique like PCR, Sanger, because Sanger has the limitation is that it only sequence a few hundred target of the gene. So just to understand the market point of view, if you have anything fast and or if you want the fast and the good thing, which is a fancy kind of thing, is not give you the the quality product, but the result is always fast as a fancy restaurant. But if you try to find the thing which is cheap and good, definitely to times like a homemade thing. And if you want the immediate and the good result, so definitely the cost is a very important thing. To understand by NGS the different sequencing option which we have. So just for for the clinician especially, the if you're doing the whole genome or the whole DNA. So if you're doing the whole DNA sequencing, we call it genome sequencing. If you just target the coding region, the exon one, which is translated into the RNA, will be the exon sequencing. And if your target is protein RNA, non-coding RNA, microRNA, will become in the transcriptome. And for the clinical setting or the clinical diagnostic setting, the more ideal is the targeted. So while you compare the results, the targeted sequencing will be more effective. The depth of the coverage of the targeted sequencing is more higher than the whole genome or the whole exome. And it will be used as a measurable or the monitoring of the disease through these, because the targeted sequencing have the specific primer, and while you are doing a library preparation, the depth will be more than the whole genome and the whole exome. So you can apply a different panel which is for lung, GI, CNS, anything you want for the target. But for genome, whole genome and whole exome is usually for the setup of research or in a clinical setting where the disease is unknown. The primary site is unknown. So it will be more work, but need the expense, need the the robust setup of the lab with a basic setup of informatics. So the cost is very important. And for clinical application for next generation sequencing, that give you the early detection, uh, the evolution or the heterogeneity in the cancer to select the treatment and the monitoring of the disease. And if I'll compare with the liquid biopsy versus the tissue, definitely the liquid biopsy give you the early result. It's a non-invasive technique, and you can monitor the disease through uh, the technique. And definitely the important thing in the liquid biopsy, which I will discuss later, the the, the tumor DNA friction is very important. So, but more important thing before these things is the tissue, how to handle the tissue. So biopsy should be viable and cellular is very important. Biopsy is should have the high tumor fraction. The quality should be the tissue should be very good. It should be well, protocol based fixation and the processing, and it should be adequate for every kind of test, like from histopathology for further molecular and other markers. So just for understanding, the ideal tissue is, the tissue which has high nuclear, component. But those who have, the non-nuclear part is not, useful for the molecular testing, especially. So for other diagram, if you have the high, nuclear or the tumor tissue or the tumor cells in the tissue is more ideal than the heterogeneous or the scattered means uh, segregation of the cells is not ideal and it will not give you the high yield of the DNA. And we should check also the important error from receiving till the dispatch of the report. For lung, the study says that the lung has a higher tumor mutation burden, which is per megabase is much higher compared to the other solid phase. So always the lung has a good the sensitivity to pick the variant, and it to understand this thing easily that as much as the mutation burden is higher, your sensitivity is much easier to pick the mutation and its variant release. So these markers, you understand or much better than me that it is recommended usually, and the different type of lung cancer. I'm not going to discuss it later, in detail. But the good thing about the lung cancer is that uh, more than through these molecular variants or molecular markers, around 26 targeted therapies available. And this is the Asian population has the higher, you know, percentage of these uh, marker. But the same, if I compare with the Dutch study, so they also have done around 1400 patients, and they found the similar marker, but the prevalence of the Asian is much higher. And this, if you compare in this slide, that the EGFR is higher than the white and again, if I compare the KRAS, is more in the European and the Western people, and there is more few target, which is some of them the higher in the white, but the remaining one is the similar percentage. And the second important thing is the targeted therapy availability. So the availability or FDA approved target therapy for these markets is now because of these discoveries, discovered. And so these are the guidelines, different people, the region or different trial have a different guideline, and these actually guidelines show the same thing that if you have the biopsy, you will classify by histopathology, but the biopsy quantity and the quality is much important for these markers for the targeted therapy. The important thing is now it's inherited epithelium. So just I want to focus this thing that they, they found some resistant mutation in the EGFR, especially the exon 2790, is also reported in the German. So she is a very known, well-known consultant in US and very active in the social media. And she reported that the family history of the lung cancer in the first 50 relative was associated with higher lung cancer detection rate than the previous heavy tobacco. This is very important. And the similar thing we found in our study that the EGFR in our two studies, its prevalence is 25%. But as I said earlier, the Asian is much higher for these kind of for the EGFR market, and the ALK is also, you know, 2 to 3% in our population. This is I'm talking about my work experience. Come to the liquid biopsy. So liquid biopsy is beneficial for those who are traditionally, not accessible for these, kind of intervention. Also, those patients where the biopsy is not sufficient, and those who are progression or the relapse, stage, and they are were been searching for the target therapy. So just for understanding for this, the tumor, DNA fraction is clonic DNA fraction is very important. So by NGS, if you have the, very minute amount of DNA, you can do the NGS. But for other techniques, you can't. But the important thing is for the shedding of the DNA should have that, gauge. But it's not necessary that every liquid, uh, you know, uh, biopsy will have the, these marker or these variants in their blood. So there is different forms and forms. Definitely the tissue is high accuracy, accessible, and you can assess the speed and invasiveness, but as the liquid biopsy is not invasive, the accuracy is not, as the tissue one has, it's expensive. You can run in the small badges because it's cost effective. You need the bioinformatics, lab and the computer specialist which has the biological background. The technically insertion in large deletion you can miss by the angio. Again, liquid biopsy, clearly not all tumor shed its DNA into the blood. Discoveries of the mutation not necessarily come from their tumor, and the resistant mutation, present in a subset may not discovered in the clonal or the circulating tumor. There is a different guideline to report. Just for quick, is all depend on the evidence base, studies. So if the evidence is, very good guideline and recommendation, so we, classify its pathogenic, then the likely pathogenic, then the variant of unknown significant. But in somatic, it also gives you the, information of diagnostic prognosis and the predictiveness. And, while you're reporting the transcription ID, its position of the DNA change, protein change, and the variant allele frequency is very important. So in conclusion, the cancer is generally heterogeneous disease. Molecular testing is very important for accurate diagnosis and prognosis, and potentially to identify these therapeutic agents. NGS is changing the algorithm of molecular testing in these patients, and our routine, it should be possible to apply the routine diagnostic in future, because it's not available in everywhere. These are our panel, which is available in our setup for different common line, means common cancer. And thank you for your attention.
Thank you very much for being done. I would like to invite all our speakers on the stage, please, for a panel discussion, as we are getting quite a lot of questions. Do we have any questions from the audience? Right, we have got quite a lot of virtual audience as well, and we have received some questions. So the first question is from Dr. Faisal Khan. Uh, so one of the hospitals in Pakistan, they have uh, started an IPC service, and they would like to know your experience in dealing with the infections and how often do you have to remove the drain?
With regards to infections,
Yes, so the question is regarding the infection rate with IPC and how often do you have to remove it?
so it's reported that usually between 2 to 4% of cases you can get infections with the IPC procedure. Well, it can be, it can vary, there can be three types of infections. One, you would say there is just a local soft tissue infection, which usually resolves quite quickly, course of antibiotics. There can be infection with a tunnel, and then the complex one is the one where it can cause empyema, which again requires slightly longer duration of antibiotics, but that can also be treated. Again, it all depends about performing the procedure, the care that you do after performing the procedure. In my personal experience, I've done like 40 procedures since I've started the service. There have been 2 cases where those patients developed infection, but they were treated promptly with antibiotics, and I didn't have to actually remove the IPC.
Thank you very much. We've got another couple of questions for you as well, Dr. Fazil, but I will ask some questions from the real panelists as well, and then I may come back to you. So there is a question for Dr. Zishan sir. What
So liquid biopsy is actually, is more efficient while but the patient is not accessible for the tumor, and it's non-invasive technique. It give you the early detection. It give you the monitoring follow-up for these targeted marker. It also give you, while you need the specific monitoring, the known targeted marker.
Thank you very much, Dr. Zishan. I may come back to you again as well, because I've got another question for you. The next question is for Dr. Haider Abbas. In a resource-constrained country like Pakistan, would you recommend continuing immunotherapy after neoadjuvant treatment in patients who get pathological complete response? Though it is, I believe, there is no evidence behind it, but we would like to know your opinion.
Yes, I think it's looking at those 2 landmark analyses where they've looked at patients achieving pathological complete response and moving on further. I think there is benefit both in Pembro and Nivo trials. So yes, I would carry on despite PAT-CR. If you had curves like the DINA trial where you see melanoma, PAT-CR does not relapse at all, but in lung, unfortunately, it does, and I'll carry on.
Right. Thank you very much. Dr. Abbas Khokhar, another question for you now. So essentially the question is, how are we as clinicians and secondly, our patients coping with the financial toxicity of immunotherapy in our country?
Yeah, this is very pertinent question. We have certain programs available, like the company which is giving us atezolizumab. There is a patient support program, and it is becoming cheaper, and we are also negotiating them to reduce further prices. However, it is still very expensive. And on the other hand, the therapies which are not available in Pakistan, like pembrolizumab and nivo, they are not only expensive, but their standards are again questionable. So we have to work together to reduce the cost of these therapies and push the policymakers to support our patients for these medicines.
Thank you very much, Dr. Abbas. Any questions from the audience? Yes, please, Dr. Amjad. Uh, can you, there's a mic there, please. Thank you.
Okay, thank you for the wonderful talks. My question from the panelist would be, in a patient with EGFR positive tumors and who has lost response to osimertinib, and we know they historically don't do well with immunotherapy. So what would be your choice of treatment? Dr. Abdullah and the panelist, anyone?
So essentially, you mean second-line treatment in
And,
osimertinib
yeah,
who progress. So the options are you go on chemotherapy, which is not ideal.
Yes.
We tend to look for MET amplification. And if there is MET amplification, there's good enough data in Korean studies where if the amplification, if it's more than 10, it works. Tepotinib works really well, and for mutation as well. So that's what we do. Otherwise, clinical trials.
Clinical trials or the chemotherapy, that would be
Yeah.
a choice.
But immunotherapy doesn't work. We know this. Immunotherapy doesn't work.
And would you be inclined to include, I mean, atezo, Avastin and the chemotherapy? Or would we just go with the chemotherapy?
Correct.
Because
So that's, yeah, so that's the next thing. So if you want to give immunotherapy, the only trial which is done is the combo, the atezo, bev, carbo and taxol.
yes,
That's a really tough one to tolerate, number one. Secondly, if you look at the number of patients in that trial, it was about 150.
50,
It's very, very small. So the only evidence to use immunotherapy in EGFR mutation positive is the Empower trial.
Yeah.
If your patient is super fit, can tolerate, yes, but I would keep it beyond. If you have PET amplification, that is much easier tolerated and works much better.
Okay, thank you very much.
Thank you, everyone. My name is Dr. Azam Jan. I'm a thoracic surgeon. My question is regarding EBUS and PET scan for lymph node evaluation. Are you, Dr. Khizar, are you using EBUS for checking all lymph nodes if they are PET positive, or you choosing EBUS instead of PET? What's the strategy for lymph node evaluation for lung cancer?
So for staging of lung cancer, any lymph node that is over 0.5 millimeter, they need to be biopsied for staging of lung, because quite often the PET scan, it gives about 20% false negative results. And when you are staging the lung cancer, it is great importance to pick up any. When we perform EBUS, obviously we do look at the lymph node, whether it looks malignant or it looks more benign. But regardless, if it's more than 0.5 millimeter, then it needs to be biopsied.
Thank you.
I'm Dr. Abdul Wahid, oncologist from Peshawar. I've got two questions. One from Dr. Zishan Saab. That you told about the gene sequencing. Is it enough to have blocks to send to you, or we have to send the fresh biopsy, please?
So the ideal tissue is the fresh, as I mentioned in my slide, but it should not be older than the 2 years, because then artifact will affect the result. So this is how you can send us either the fresh sample in a formalin fixed tissue, or you can send us the
blocks.
the block. Yes.
Yes.
But with histopathology report and other details.
And how much is the cost, please?
The cost for I think for NGS,
Yeah.
which we have in our Khan, which is the 15 gene hotspot panel, is around 80,000, and just for the the EGFR, I think is around 40K, and the ALK is around 30 or 35K.
Okay, thank you.
Thank you.
My second question is from the Dr. Coker, and others, that you told, is there any role of combination of chemotherapy with the immunotherapy? And what are the results? What are those selected patients? We can give it in all the patients.
Yes, there is a role of chemotherapy in combination with the immunotherapy. And even if the PDL1 is negative, it can be used and it is found to be more effective in particularly in squamous cell carcinoma. So I have mentioned that in my talk as well, there are certain trials which favor the use of immunotherapy, immune checkpoint inhibitors along with the chemotherapy.
Yes, and with the treatment, as this CA lung, advanced one, it becomes a chronic disease. So you will have to treat them for 2, 3 years or sometimes 4 years. So how will you modify your chemotherapy protocols or with the immunotherapy?
There is rule of maintenance immunotherapy, and if the patient is stable, the disease has responded, and there is less burden of disease or the disease has disappeared, then only maintenance immunotherapy can be offered to these patients for longer period of time.
So maintenance can be given.
Yes.
Would you like to have some, what they call it, a short break and treatment, what they call it, treatment holidays, and then start with the other?
There is no evidence at the moment, but we do practice it in our population. We know that there are financial constraints, there are toxicities associated with these medicines as well. So we do that, practice those, but in practice, we have seen that when the patient is gone off therapy, there is relapse and there are complications that arrive in these patients. So we tend to continue therapy most of the time if the patient is affording and tolerating the therapy well.
Okay, thank you.
Assalamu alaikum. Thank you so much to all the speakers and the management. Kindly bear with me. I have two questions. I am basically a general surgeon from Cohort, and my name is Dr. Hira Ijaz. My first question is from Dr. Khizar, that how the video-assisted VATS can be done under local anesthesia, because in VATS we have single lung anesthesia. Then how can you avoid the injury to the lung while doing the procedure under local anesthesia?
Now, again, the way it is slightly different from thoracic VATs is that thoracic VAT is mainly used for quite extensive operations such as removal of the part of the lung, lobectomies, and so on. Here, what we are doing is just taking some biopsies from. It's more or less similar to doing the IPC procedure. Patients would usually have pleural effusions and identified lung nodules. So it is done under all aseptic technique. We give a bit of local anesthesia, and then, with the help of the video-assisted thoracoscope, we identified lymph node, the tissue, and obtain biopsies.
I just want to know that every patient has different body habitus. Then how will you avoid the injury to the lung, because you don't know where exactly is the space?
So we essentially perform an ultrasound scan prior to the procedure.
Okay. Right.
So this is a routine practice. You wouldn't perform the procedure without ultrasound guidance. So first of all, when the preparation of the patient, the first thing you do is to identify the area where there is effusion. Okay. So then you mark the area and then put all sterile drapes and then start the procedure with giving an incision. So it is done under ultrasound guidance.
Right. Thank you so much, sir. So my second question is from Dr. Zishan. Kindly, if you please highlight the usefulness of liquid biopsy for GI stromal tumors and its availability in Pakistan.
For which tumor?
For GI stromal tumors. Maybe the question is out of context here, but is there any usefulness of liquid biopsy for GI stromal tumors?
So the main thing in liquid biopsy, even from any tumor, is the circulating tumor DNA friction. So if you have the circulating DNA friction in the plasma or the blood, then you have the high yield of that DNA, then you can apply in any, modalities like NGS, or if you want the multi-gene by PCR or multiplex. So all is depend the yield. So if the GIST has, as you know, that, the PDGFR and the KIT mutation, especially the exon 9, 11, and 20 is very important, and you have the enough circulating tumor DNA fraction, you can apply in the, NGS, or if you want to do the isolated test.
Thank you.
Thank you.
Thank you very much. Actually, in the interest of time, I think we will have to move on to the next session. I would like to thank all of my speakers for traveling so much, for their wonderful talks. And don't get disappointed, they are around this afternoon. So if anyone would like to catch up with them at any point, they will be more than happy to meet you and answer your questions. Thank you very much.